Dr. Mahesh Shanmugam, sir, the Chairman Scientific Committee of Veterinary Society of India, a very dynamic surgeon and a great teacher. I would like to request Mahesh sir to speak on how would I excel as a program director, because of course in India, but in abroad, the program director has a huge role. You might be aware of it, sir. So definitely, I would like to know more about this on this topic. Over to you, sir.
Thank you. And this is a talk which was given to me how would I excel as a program director. So I don't know why Dr. Chitra asked me to speak on this. Either that will be a good learning experience for me and so that I can improve, or that I'm already there. I don't think it's checking the situation probably. She expected me to improve further. So, like, look at it from the perspective of the fellows. Like, the fellows look at it as like this: sort of the fellowship is equivalent to budding chances. So that's what they want. But is that what it is? A good fellowship is something which makes a complete physician. Maybe you wear the Raven suits or not, but then it makes you a complete physician. So instead of telling them what I would say as a complete program, because like I will talk about like what we import to our fellows, and then see that kind of makes up the complete program and add up on the things. So I call this the 10 Commandments. I have spoken this earlier in other forums also. One of the as well. I think she was maybe familiar with this. So let's look at the commandments. Number one is thou shalt be familiar with your instruments. Veterinary surgery is something which is heavily patient dependent. So an optimal surgical outcome depends on efficient use of equipment. Maybe the microscope, etc. So unless we know the capabilities and the limitations of a machine, we cannot use them to the optimum and give optimal surgical results. So they ensure that the fellows do read the manuals as well as discuss with the visiting technician about the mechanism of the machine to know the best capability of the machine. Next is thou shalt know your case. So I was doing sclera buckling with under Dr. Chandra supervision, and he told me, made a comment, the cobbler can do a better buckling than you. So all the 15 years of doing medicine, and then I thought, like, oh my God, this is where I am. I might as well have become a cobbler 15 years back. But then he came up with a subsequent statement. He said, like, the difference between you and the cobbler is actually the way you suture the stitch. The sclera buckling and the cobbler, how he uses pretty much the same. But actually, he does a much better, precise job of placing sutures. The difference is, you know when to do a sclera buckling, versus the cobbler doesn't know when to do a sclera buckling, or rather than how to do a sclera buckling. So that's what I will try to import to our fellows. So if there is a case which is there for surgery, that like what Mahesh said, we make a plan. So you read the case, like you kind of know this particular patient needs a sclera buckle, this patient needs a vitrectomy, this patient needs a complete vitrectomy. So look at the case and formulate a plan. Thought process is very, very important. That's what we try to teach them how to do that. Third is you shall use all your senses to work. So that's like you develop the sense of keeping one ear on the monitor, one ear on the machine. So if the patient wants to have the urge to micturate and the pulse will go up, and if you're doing a surgery on the GA and you're hooking the muscle and your anesthetist is busy looking at the WhatsApp, so you may be the first person to pick up that the patient is going for a bradycardia. So there is music also now, so maybe like you may be the first person to pick up bradycardia. And again, you know what the machine sounds like. So if there is a little change in the note of the machine, you know something is going wrong with the machine. So that's what we train them for. Number 4 is like thou shalt not covered shortcuts. So here is a patient who has dental attachment PVR, and if you don't peel all the membranes and you think silicone oil is the substitute, obviously it is not. And similarly, this patient needs a belt buckle, placed with belt buckle. So don't opt for shortcuts, thinking that silicone oil or not opting for a belt buckle is a solution in a particular case. So despite which the patient may recur, but you go home in the hope that like you've done your best and hoping that it's fine. The patient recurs, after that you know that the disease is just plain one. Number 5th commandment is thou shalt not bite more than you chew. In the initial stages, what happens is like you tend to take up more complicated patients, and then like we get stuck up. So you're mentally and physically stressed and tired, and the subsequent patients in the list get out the raw end of the stick because they're tired and frustrated. So we should know our capabilities and start off in a great fashion, taking up simpler cases and building upon them rather than start off with the difficult cases and then making them have a negative impact on. Number 6 is thou should not cover the neighbor's equipment. So very often you have the newly minted fellows coming in, joining a place, coming and saying, I want this particular detective machine, that particular laser, this particular microscope. It is not the detective machine or the laser or the ones which give you the benefit or the best surgical outcomes. It's actually the surgeon himself. So it's a marriage between the surgeon and the equipment what we have is what gives the optimal surgical outcome, and not having the best of the equipment or best in the market at that particular point in time. Ultimately, somebody said that the happiest people don't have the best of everything, they just make the best of everything they have. So this happy marriage between the equipment you have and your capabilities is what gives you the best results. And we also focus on the ergonomics. So thou should have long wear life provided you sit right and tight. So the way you sit and the way you operate, like sit erect and make sure that like you operate in a very relaxed way is what makes you a better surgeon. A frustrated surgeon or a surgeon who has a back problem because they sat in a wrong posture is a tired surgeon. So a tired surgeon does not give a proper results, optimal surgical results. So this is something which we focus on in this semester. Commandment number 9. Thou should not blame the patient or the disease and take responsibility for your action. This is a very, very important point. So taking responsibility is something which doesn't come easily. So, and in VR it's very easy to say. The patient has a recurrence to say that like this patient has a recurrence because the disease was bad. So the PRD was bad, the PSMLA was dense. It's very easy to blame. So there are two types of surgeons. One who blames himself for every failure, the other one who blames the disease for every failure, or the patient not maintain position, patient not come on time. So both have their pluses and minuses. The one who blames himself actually is better for the subsequent patients because he goes back, analyzes the surgeries, reflects on it, and does a better job the next time. But the one who, and it's good for the subsequent patient, but it's bad for the surgeon because there's a lot of angst. And he kind of tends to blame himself, and that gives rise to a low self-esteem. The other one keeps blaming on the disease, so it's bad for the subsequent patient's office. And so it's best is to walk the thin line between blaming oneself and blaming the disease. So somebody said in China, the Chinese proverb which goes like, who blames others has a long way to go on his journey, and who blames himself after that, who blames no one has arrived. Commandment number 9 is thou should empathize with the patient. It's usually a patient say this is a TID patient, this is a PSMLA patient, the regarding patient. It's not that way. It's a 41-year-old single earning member of a family who has got diabetic eye disease with fractured detachment. He's wondering how he's going to support his family in the next few years. So if you note that or a pregnant lady who is blind, like bilaterally blind because she develops sad. So if you know that aspect of the disease, then you empathize with the patient, and that gives you the best outcome to your patient. So it's the William Oscar who said a good physician treats the disease, great physician treats the patient who has the disease. And commandment number 10 is thou should remain humble. Humble we are surgeon is a learned surgeon. The moment we think that like we know everything is when you get hit. And other than this, one slide which is going off. Yes. And the days of I know it all has gone. So the moment I sit around telling the patient like this is what your diagnosis is, what the treatment is, all my fellows are behind me googling the diagnosis and calculating the diagnosis to say that if I'm right or wrong. So if you don't know, best is to agree that like I don't know what the disease is, let's find out rather than saying, oh, this is what it is. They know that like you're telling you're putting a fast one and they lose that stick for you. Other than this, yes, like Gopal mentioned, we go to a structured training. There is progression. Initially, there was steps in surgery, then there was simple surgery, then there was complex surgery. In the OPD, yes, they can dispose of patients after 6 months of training, but we come in the patient from the beginning and always have a consultant's opinion before they advise a surgery. And we do have regular class and journal exit exams. So number of surgeries twice this debate always goes on. This Association of University Professors of Ophthalmology Fellowship Certification Committee in the US has suggested that like they do 100 vitrectomies either by themselves or the supervision under onboarding buckles. At our place, yes, the fellows do around 100 vitrectomies independently. Buckles is a bit of a difficulty. And initially under consultant supervision, the consultant stands with the OT and supervisors, and subsequently they are able to do the surgery by themselves. And of course, I agree that independent surgery may not be possible in every institute. Surgical audit, yes, we have to have dedicated PR classes on surgical cases which have gone wrong. It may be consultant cases as well as fellows cases which we discuss in the class. And the operating fellow will make sure that they see their own post-op as well as we tell them to see if they have records. Clinical skills, they do hands-on FFA, ICG, OCT, lasers, RFSD, lasers, and they do workup opening patient. We emphasize saying every patient is a learning opportunity. It may be in the past, in that particular case, something is there to learn from every patient, that's something to learn. Research, yes, they all have to do complete 2 papers as a primary author, and there are actively reported ongoing studies at present that are our work of the VR safety. So to summarize, a good fellowship program is not only cutting, it should inculcate life values and training in patient care, training and research to make them a complete physician. Thank you very much.
Thank you, sir, for a wonderful presentation. Sir, as a program director, now the fellow comes to you for the fellowship interview. He says that, sir, I have already done 10 vitrectomies in the previous college where they have learned. And I have a good hands-on training. I have done 100 papers. I have done all those good surgery. The other fellow, you see, a very bright student, but not having good surgical exposure at all. So in these cases, usually we tend to select the fellows who are already have a good hands-on experience. And sometimes the chance can be devoid to the people who are actually want to learn more, but unfortunately in their previous medical colleges or institutions, they might not have got a chance. So how do you tackle these situations and how do you select these students for the fellowship interview?
See, as far as VR is concerned, we need to see if they are going to speak to VR. If somebody comes and tells me, I want to do cataract, but if the nucleus stops, I want to do it, so I go to the fellowship, so he goes down with this. So a person who is dedicated and doing VR is what we select that. And if he has done some vitrectomies in some place, then you probably look at the kind of place where they if it's an unsupervised vitrectomy in a medical college where they don't have a trained VR surgeon, then probably he stands a less chance as compared to the guy who really wants to do this surgery, but he has not had an exposure. Because we have this 2 years to train them into doing that. So that's how we look at it. And it's just not what experience they have. And the clinical skills is what we look at, knowledge is what we look at, and the enthusiasm and how badly they want to VR is what I look at.
Lalit sir,
my approach is slightly more aggressive. I will demotivate that person not to do VR. The reason being that the same thing actually, I have to derive how much passion or interest. That's what is distracting. So what I'm saying is, I will try to demotivate he or she because I want to know or understand how much he or she wants to be into here. Because if it's basically fellowship, like you said, patients who know, Mahesh also was saying. So I have to see how much passion there, how much he or he wants to learn. It's not important if he is briefly trained in a couple of techniques or this thing. But if the first category, what you said, if he says that he will stick to it for 3-4 years, and if he can, this is example I think from recent interviews what we had in Central Society. So we selected the first category because she is directly wants to do it. Why I demotivate? Because she graph or learning is a long journey, and if she still want to do VR, no, then it's my job to train her and go in
Pramod sir, they have not done any cataract surgeries at all. He's a very nice, or he or she is a very nice surgeon, and they want to do direct VR fellowship. So, what is your thing? You post them for the cataract for 6 months, get a good hands-on training, get a good tissue handling, and then come back to the VR?
Actually, this question is relevant now as a post-COVID era. Lot of people have just not got any hands-on at all. But we also learn along with that people have done a lot of surgeries and then realize they're doing a lot of complications, lack the depth perception. Would have done cataract like it. So initially, as a routine protocol, what we do is everybody they go to our spin clinic, go see their depth perception like a hand-eye coordination. I mean, unfortunately, we really surprised that a lot of people they need a post-graduation, but they do not have proper hand-eye coordination and lack depth of perception. So that is what we, as a routine, as an induction training, before the India, they go through this checkup. Yes, and coming back to your question, yes, that unfortunately the problem is because when you want to do VR, you do not have time then to train first to tissue handling, do cataract and all those things as part of curriculum. So it's not fair for them, coming to previous question, but there's no other choice. So probably they can go, get some training done, at least learn how to identify all the cataract, but learn how to handle well, and then come back probably with both more or less similar theoretically, because that's the way person most of the time during implement their experience probably is some way will go, but ultimately how desperate person is. But that we cannot avoid because you are not here to train again from cataract surgery, go up, crash, and then bring them back to here. That your tenure is not adequate enough for that. It doesn't permit. I know it's injustice for the we don't have.